But first, I'd like Jan to just give us a bit of a brief overview on what we're trying to do with the future of clinics and where we are in that process. Okay, Jan, over to you.
So good morning, everyone, and welcome to this second of a series of webinars. I'm delighted to be welcoming you on behalf of the Kootenay Boundary Division of Family Practice. I'm guessing the majority of you are aware that KB Division has been facilitating an engagement process, exploring the potential and the appetite for a network of community health centers or clinics in our region, and to learn from folks who are directly involved in community health centers as practitioners, managers, and advocates. I mentioned that this is the second of a series of webinars, and the purpose is to facilitate focused learning and discussions on different aspects of making the transition to and operating community health centers. Each webinar is an opportunity to hear directly from these experts and to pose questions of them. And the good thing is that these webinars are being recorded, so you might go, gee, I wish so-and-so had been able to hear this, and we'll be able to share that with you and you can pass it on. As Kate mentioned earlier, our webinar today, we're focusing on community-centered care, and having more than 40 years of experience in community development and community education, that's a particular passion of mine. We're looking at how co-located services and teams can best meet patients' needs, considering the larger aims such as team-based care, accessibility, attachment, diversity and physician satisfaction, as well as exploring payment models and how they impact. And that's just about everything, which is a lot to accomplish in an hour. So with that, I will sign off. Well, I participate in the webinar and leave this now to the experts.
Thank you so much, Jan. I just want to go over briefly what our agenda for the day is. We've had a bit of a welcome and overview, and I'm going to introduce our panelists in a minute. We'll have a structured dialogue with them. So I've kind of had some tailored questions I'll ask each of them, and they'll provide an overview of what they do and how it really relates to this. And then I have some follow-up questions, so we'll have a bit of a dialogue, and they may have questions for each other also. For the second part of the webinar, we'll really open up the floor, and we'll be addressing the questions that you have typed into the chat box or into the question and answer box, and be able to really address those. And then hopefully at the end, we'll have time where we can enable people to raise their hands and ask questions directly. Before I jump ahead to introducing our panelists, I also want to acknowledge Dr. Ellen Smart, who is also a member of our board and is also a member of our advisory group for this initiative. So welcome, Dr. Smart, and really glad you could be with us today. So we're very fortunate to have these speakers with us. All of them have just great and very diverse perspectives in terms of this community-centered care, different ways to facilitate it, both from a practical perspective and also an academic perspective. So we'll be starting with Dr. Price. He's a family physician who works in Victoria at the Kootenay Community Health Center, and he's also the lead faculty for informatics at Family Medicine Residency Program. His interests are in the health system improvements. He's done a lot of work on continuity of care. So he has a long experience both working practically in community health centers and also from kind of a research and academic perspective. Rhonda Huff has been with the Yakima Neighborhood Health Services, which is in Yakima, Washington, in central Washington, since the 80s. And she currently serves as its Chief Operating Officer and the Deputy CEO. She is very dedicated to ensuring access to healthcare for homeless persons and other vulnerable populations. And she does a lot of work really helping the health center that she works with to link with those other community services and those other community organizations. And we've heard from her organization that her work and experience and expertise has been really key to structuring that co-located team structure and making these different partnerships work. Dr. Jocelyn Pedrosa is the Chief Medical Officer at the same Yakima Neighborhood Health Services. And she oversees a very diverse group, multidisciplinary team of clinical staff and different providers in the areas of primary care, behavioral health, pharmacy, nutrition, outreach, and housing to really provide very comprehensive and holistic care for the center's patients with a particular focus on special needs, agricultural workers, homeless, and people in need of housing in Yakima. Dr. Selena Lawrie will hopefully join us later. She's slated to join at 9, so when she appears, don't be surprised, and we're very pleased that we're going to be able to have her join us. She has been instrumental in creating the Supporting Team Excellence with Patient Society and the Orchard Walk Medical Clinic in Kamloops. That's a very new development. They've been working on that since 2017 and just opened their doors in this past year. And that provides general family practice services with a focus on community-oriented care. So she served as STEP's founding president and the board director, and she's currently the medical officer, lead medical officer for STEPs. So it's a great panel today. We are looking forward to hearing from them, and we're also looking forward to hearing your questions, which can be directed to them, so that we are really looking forward to have an interesting dialogue and a great exchange of ideas. So with that, I'm going to turn the floor over to our first panelist, Dr. Price. And I'd like to ask you, Dr. Price, from your perspective and experience, how can community health centers support and facilitate a team-based approach and continuity of care?
So there's a couple of parts in there. First, I'll just say that my PhD was a little while ago. My son is 10 and I submitted it the day before he was born. So the information is a little out of date, but that's okay. To answer the question, so I've been working in community health centers for about 18 years now in different locations in Vancouver and mostly in Victoria. How does it facilitate continuity of care and how does it support the patient? I think there's so many ways that a community health center does that. And I think it's not different in some ways to primary care in that there are relationships being developed and there's continuity with your primary care provider, but there's also continuity through the team. And I think that becomes really important, especially for patients that need additional service and support. Sort of jumping off that a little bit is the idea that a community health center generally tends to be a bit more responsive to the community, the population that they serve. And so they're adapting a bit more. And a specific example of that would be in our clinic, we're doing much more outreach than a typical primary care clinic would, because that's what's needed for our population. So we've changed our structure and we've created small teams that support different facilities to get access to care. I hope that sort of helps answer that question in less than 3 minutes.
Mm-hmm. That was very brief indeed. Thank you very much. So I'm going to move on to Rhonda and Dr. Pedrosa, who are going to share the perspective from Yakima. So Rhonda, if you could start by just telling us about what community-centered care means in Yakima, in your center, and how you've established partnerships that help to address the social determinants of health in a holistic way.
Sure. And I'd like to start with a couple of our slides to help your audience give a little perspective about who we are. So if you could put the first slide up, that would be great, Kate. I would start by saying, we thought we had a great understanding of community-centered care until COVID started. And that brought all new meaning to us here in the Yakima Valley. For several weeks, we had the highest rate of COVID on the entire West Coast. And we have been in regular meetings and discussions with our hospitals and other community health centers in the Valley, just trying to address the need in terms of how to best serve not only our patients, but also in our community. But this is our streetscape, as you see here. And while as a community health center, anyone is eligible to come and see us for services, the majority of people that do come to see us are low income. And typically on our state Medicaid and our federal Medicare insurance programs, we're a valley of about 250,000 people. We're both rural and metropolitan. So we have, our largest city, which is Yakima, is about 100,000 people. But we have small communities that also have, 2,000 to 3,000 people. We have 9 sites in the valley, and our smallest clinics are in a community that's about 3,000 people. And as I said, anyone is eligible to come to us. And when we talk about co-location, we really work, try to work beyond co-location and work more towards integration of services. And you can go on to the next slide, please. And the majority of our programs that we have services are in partnership with other organizations. So, and we learned a very long time ago that as an organization, we're much stronger in partnerships. We're as strong as the partnerships we have with others in the community. We have a lot of poverty in our valley. We're a very agricultural community. We are known for our hops and our wines. And so the agriculture is really the foundation. So there's a fair amount of wealth in our community, but there's also lots and lots of poverty. So these are just highlights, pictures of our sites, and we do these in partnership with many other organizations. And we sort of identified, what those needs were based on the needs of our patients. So we have, in addition to being able to have services that we provide in-house, we also try to partner with organizations that are like-minded and also that meet the needs of our patients. And so we started by, looking and reaching out to partners that could meet our patients' needs in ways that maybe we could not. We knew that, the vulnerability is always in the handoff. And so the stronger we could make those relationships, both for our patients and with our partnerships, then the stronger that we could be and the more successful we could be. So I think I'll stop there for that question. And actually I have one more slide, so let me show that one before I pass it off to Dr. Pedrosa. And this just gives you a picture sort of who we are and in terms of integration over the years, what we have come to be. The left side is really what we do for our general population and all of our services. And again, as I said, we have identified what we needed to add based on the needs of our population. So the services we provide, and then we target services on the right for our vulnerable population, whether it be our agricultural workers or people experiencing homelessness. And we have added over the years the services really just based on the needs of the people that have come to us for help.
Thank you very much, Rhonda. That gives us a picture and helps us to understand, especially I like what you said about beyond co-location and looking at integration. Dr. Pedrosa, could you tell us about the multidisciplinary teams that you are managing and how they work together and with these other actors to contribute to positive patient outcomes and a community-centered approach?
Sure, thank you very much. If you go to the next slide, I'll start with that. So I should start by saying that I came here in 1996, straight out of residency, training in pediatrics. And over the years, I've had the pleasure and privilege of watching this organization grow and become the multidisciplinary clinic that it is now. And I can say that, for the most part, it really, really helps with recruitment. Almost every single provider that we've recruited in the past few years make comments about how important our multidisciplinary team structure is to their decision. And it certainly, I left for 2 years and did private practice, which was great, but it was very different. And I came back actually in 2013 because I missed this multidisciplinary approach. So if you go to the next slide. Yes, so we can pull different team members into the exam room to give patients what they need while they're here. So anything from dietary advice from dietitians or crisis intervention by a behavioral health specialist for a suicidal patient, or a care coordinator for a family who's overwhelmed by multiple specialty visits because their child has a lot of special needs. We've really learned over the years that warm handoffs, as Rhonda said, is crucial and really more effective. We learned that patients usually don't show up when you refer them to a dietitian for whatever reason, but if you can bring them into the room you know, they'll come and see me, but the dietitian knows more about, you know, practical tips, and they can teach the patient while they're here. And that's been very, very effective. The other advantage is that, you know, team members, we've learned to learn from each other. So it's not unusual for our psychology intern, for example, to give educational sessions during our provider meetings. So we've had them present on things that we see as practically applicable here within our walls. So anything from depression to transgender care to de-escalation in the exam room, we've benefited from that. In turn, other staff members like care coordinators and behavioral health specialists have sat in on our educational sessions. So most recently, we had an educational session on the use of buprenorphine in the management of chronic pain, for example. And if you please go to the next slide. And one of the key advantages as well of having multiple disciplines within our walls is that we share one medical record. So here, this is a great example of a homeless patient with opioid use disorder and who was participating in our medication-assisted treatment program, who had been arrested and relapsed. And you can see from the chart, and you know, this is a few years old, but it continues to this day, that you can see, we can see that there are multiple specialties that enter documentation in the medical record. The care coordinator, behavioral health, psychology, the medical provider, our homeless team, and that hotspot drop-in is actually our warming center in the winter. And so we do a lot of outreach as well, and it's not uncommon for us to be looking for patients. And if we can see that they go to the hotspot, we know where to look for them. And I have to, a word of caution though, this is great. Technology can get you so many things, but it's more important to foster a culture of a multidisciplinary team, because you really have to have a culture where you don't operate in silos. So having all these disciplines in one medical record won't help you if you're not used to reading each other's notes. And if you go to the next slide. And so I've learned over the years also that the differences in a community health center, you know, has its, the opportunities that it presents can also be challenges. So again, it really speaks to developing the culture that you need to succeed. So at our community health center, we set the expectation that we work off of the same protocols based on clinical guidelines. And so an example would be that we used to have a lot, this has to do with opioid use and chronic pain. And we used to have a lot of incidents involving irate patients who were mad that certain providers would not fill their opioid prescriptions when others would willingly and easily do so. Things got a lot better when we beefed up our protocols, and our providers were expected to adhere to the protocols, provide documentation to support deviation from the protocols. And we also initiated a system and process of external peer review and follow-up. So this really paid off. So when we started this process, we had a lot of patients on opioids chronically, almost 400 in 2017. And you can see this is like an older slide, but over the course of less than 2 years, we were able to reduce that by almost 50%. And that the rate is even lower. I couldn't get the report to run accurately, you know, a couple days ago, but it's even lower now. And we were able to in a responsible way that didn't involve kicking out a lot of patients or just disenfranchising them. We've been able to get them to safer medications, offer them medication-assisted treatment, behavioral health, or whatever it was that they need. So we're really happy with the outcomes that we've seen with this issue. And that's it for me, I think. Providers are more satisfied, and we have much fewer incidents of irate patients for this issue. And when they do, it's an easier explanation to explain why we do things the way we do.
Thank you very much, Dr. Pedrosa. So I have a couple of follow-up questions I'd like to delve into, and maybe I'll direct this first one to Dr. Price. But as a practitioner, what do you see as sort of the opportunities and challenges of working in a community health center? And what would you advise practitioners as they consider sort of and think about shifting from private practice to a community health center in terms of, from a physician perspective?
I think there's a lot of opportunity. I just listening to what Jocelyn and Rhonda were saying, it echoes a lot of what my experience has been around working together. I mean, that's a huge part of it, right? So there's that continuity of the record across the team. I think in BC, one of the things that for us it's a big part of this is that we do less and less referral out because the team has the support internally. And that's that concept of a patient medical home, but even much more so. So we have pharmacy, nursing, psychiatry in reach, dietitian, and all that in-house, so that we work together as opposed to referring out, and that's huge. So that's a real opportunity. And then I think also heard that idea of learning across the group. So I walk, knock on the door to the pharmacy, and I can ask some questions that moment, and that is huge. I've been in practice now for almost 20 years, and I barely remember the doctor's lounge in the hospital. It's really not part of my day-to-day life in the last 15 years. But the community health center has replaced that. So I have that social connection. That's a big piece. The transition to people who are thinking about this, the one for me that seems like an easy giveaway, but is often a hard one, I think, is all the day-to-day work of running a practice. I don't do a lot of that. I do interesting parts of helping the community health center. In the time of COVID right now, we've done lots of things, but I'm not managing HR. I don't have to do the laundry, those sorts of things that a small practice might be doing. And I do have colleagues that take the gowns home at night to wash them all for the next morning. That's not part of what I need to do as a physician, as part of the team. So on one side, it's giving up some autonomy, but there's also getting a lot of freedom in that too. And I think that's an important thing to, that's a big shift for a lot of people. For our newer colleagues, it's a no-brainer. They don't want to do the laundry. Thank you very much. They want to work in a team. They want to have certain flexibility that the team provides, so that we essentially have built-in locum to our community health center, and that's huge. And it doesn't always work out, but at least it's there and there's capacity. And so actually a lot of my role lately has been to be there to be a bit of a sort of an overflow, as opposed to trying to find that locum to cover you for 2 weeks of vacation. We can do that internally. Those things are great. And being able to work across the multidisciplinary team is also fantastic. Those things are really, really the benefits for me. But then I can see that idea of if you've been running your own business, there's a real hesitation to losing that sense, that autonomy, that piece of your practice.
Super helpful. Thank you very much. Rhonda or Dr. Pedrosa, would you like to add to that at all? Any further thoughts on kind of that, particularly from practitioner perspective of, what the shift means. And you mentioned that recruitment is fairly easy for you. What are the things that really attract practitioners to join?
Well, I'll start. I know that when we were talking about this yesterday, we have, well, Dr. Pedrosa is one who came back from private practice, but we have about 3 other providers who have come to us from private practices, and a couple of things Dr. Price just mentioned, but certainly not having to run the business end of things, it was certainly a driver for them. And when they came and talked to us, and 3 of them have been with us for, 7, 8 or more years now. And so, I think that the challenges for them, and again, Dr. Pedrosa talked about this in her comments, was, really conforming to a group model. They love the idea of the team approach. That was not a hard sell. But the initial idea of working under shared protocols, I think, has been a challenge, at least for a couple of them in the beginning. As a community health center, we have lots of rules. We are Joint Commission accredited. We are a NCQA, patient-centered medical home. So some of these things are by choice. We do get some federal funding from our federal government, and so there are lots of rules and regulations that come with that. So it's very different. That sense is very different than being in a private practice. So there are definitely some trade-offs. But I think because we, the folks that are here have stayed with us for so long, I believe they believed that it was worth the trade-off to be part of a team, and the structure of the organization, I think, has well paid off for them. So what would you add?
Yes, so like I said earlier, it really has to do with the acceptance of a certain type of culture. There is ease in recruitment, but also that opens you up to turnover. And it's difficult to have to train folks again and again. And it's, you always try to learn about what type of personality and work ethic would work best in our setting. Just because you're intelligent or talented medical practitioner doesn't really mean that you're going to be successful in this sort of setting, because as Rhonda said, we do play by a lot of rules and it applies to everybody. And some people have more or less difficulty in adapting to that. We also have a gazillion, it feels like a gazillion quality measures that we are always trying to meet. And so our culture is we try and meet that and address those regardless of what they're coming in for. And that could be a lot of work. And that also requires quite a high level of documentation, and documentation in a certain way. So we pull a lot of reports, quality reports, and we don't get to pick our patients. I think that might be a struggle for some people. We don't fire patients for not showing up or not following what you say. We really try and try to really learn what it means when we say don't get furious, get curious. And that's very difficult because it requires quite a bit of humility and patient-centeredness that we're always trying to learn.
I think the one other thing I would add is, we are a mission-driven organization, and I mean that philosophically, not religiously. And as a patient-centered team, the doctor is not always in charge. In fact, the doctor is often not in charge. They're a member of the team, and everybody on the team really has equal weight in terms of trying to identify the patient's needs. And when Dr. Pedrosa mentioned, just the culture, that's really the culture of our organization, is that the doctor is an important member of the team, but there are also other important members of the team. And that's, and so when we interview people, we're really looking for that kind of philosophy. A lot of we have providers that have come to us after serving in the Peace Corps. And I used to, a long time ago, I used to say working here is like working for the Peace Corps, but you don't have to give up the running water. And it is that kind of mentality. That's the people that typically are the most happy working in this organization. Flexibility, non-judgmental, and have that sense of mission.
Great, thank you.
Can I jump in on that?
Sure, go for
I
it.
agree with so much of what you said. I want to highlight it in the BC context. The community health centers aren't in that same kind of reporting difference that is in the US of so while absolutely we do have reporting to do and our funding structures are a little bit different, it's not quite the same. So I don't want people in Kootenay Boundary to think, oh my gosh, then there's this whole other stream of it'll be not that different in terms of the care expectation. There may be some differences, but it's not as stark a difference.
Thanks for just clarifying in terms of the context, Dr. Price. Appreciate that. I just wanted to let everybody know that we have Dr. Selena Lawrie with us, and she's just joined now. We're going to see if she can turn on her video. But Dr. Lawrie, if you're set up, could we go ahead and ask you a question? You might need to unmute there. Well, we can come back to you, Dr. Lawrie, if there's any technical difficulties, because we're keen to hear from you about your experience at Steps and Orchard Walk. But I'm going to go ahead and ask one more question, and then we'll come back to you, Dr. Lawrie. So the next question I had was a bit maybe looking at sort of complementary community and private services. So we talked a little bit about it earlier, but I'd like to hear from kind of these different perspectives in terms of what complementary community and private services could and should be co-located with the CHC, and how integrated could they and should they be with sort of the team-based care of actual practitioners. And I think this goes back to something you said earlier, Rhonda, about you're trying to move beyond co-location and actually look at integration. So I'm interested to hear a little bit more about that from your perspective. And Dr. Price, I'd like to hear from your perspective on what that could look like and how, particularly in the BC context, your experience in terms of linking with other services and how integrated they can be, and how we can make that work. Why don't we start with you, Dr. Price?
Sure. I was typing the answer to one of the questions in the Q&A at the same time around in-reach. So co-location and integration, I mean, it's huge. As I said it earlier, I do outreach, but also there's the community health center. Really what should be in your community health center, I think, depends on who you're serving. You're population focused. Who are you taking care of, and what do they need? And that can be driven in combination with your patients who are giving you that description. We have a board. That's another question, a community-based board that looks at the needs of the population and helps us decide what do we want to do, how do we want to expand. For us, critical to have primary care, nursing, to have a pharmacy, to have mental health support workers. We also have, as I said, dietitian. We finally got physiotherapy a couple of years ago, which was great. Psychiatry. So I mentioned it in the Q&A. We have psychiatrists that come in, as well as other specialists that will come in for a half day, and we will have pre-booked our patients to see them. They also write in the same electronic record. One anecdotal story to show the importance of mental health is the way our clinic is set up. It's like a figure eight, and on one side of the figure eight is more the clinical, and on the other side is more the counseling rooms. So there's always a fight for an exam room that sits right in the position that you can see across the figure eight, so you can see if the door of the counselor's room is open. Because then you can peek out your door and say, actually, I want to go down and see Sarah. Come with me, and I want to introduce you, and do that warm handoff. The trust relationship that I have with a patient then can spill over very quickly to another member of the team. And that becomes really, really important, particularly in the population that we serve, that that if the trust isn't there, they're just not going to be able to make it to that person up at the hospital, or, you know, even a block away in a different organization. So having people local is really important that way. So I hope that starts to answer that question a little bit.
You're muted.
Kate,
Kate.
you're muted.
Sorry, Dr. Lawrie, welcome so much. I really appreciate your joining us. You're muted too, Doctor. There you are. We can hear you now.
Can you hear me now?
Yeah. So thank you for joining, and we really appreciate that. I had a question to sort of get us started with you. Can I tackle that?
Yes, and my apologies that I just came in and I've missed the beginning of the conversation.
No problem. So just to remind everybody, Dr. Lawrie has been involved in starting up the STEPS Society in Kamloops, and most recently opening the Orchard Walk Clinic. So I've been very involved in very recently setting up a community health center here in BC, in the area similar to ours of the Interior Health. So Dr. Lawrie, I wonder if you could just kind of share with us, based on your recent experience with STEPS and the Orchard Walk Clinic in Kamloops, and your role there as a medical officer, what do you see as the challenges and opportunities that the community health center structure brings in terms of team-based care?
Can I start off? I don't even know what you need to know. What do I see as the challenge? It's so hard for me to know.
Well, tell us just maybe a little bit about your experience.
Well, I think that's more important, because as I sort of see what you're doing, I don't want to say we did it backwards, because we did what we did on purpose. And what did we do? I'll back up super quick with the quick history. Our society and our community health center stemmed directly out of a GP for Me work with our Division of Family Practice. And in Kamloops at the time with GP for Me, the estimation was that we had 30,000 people without a family physician in our community. Our community is about 90,000 people, probably about 95 now. So a huge problem in Kamloops. Part of the GP for Me work was around essentially an incubator model originally. The idea was, how do we mentor young family physicians and transition them, you know, with older retiring physicians into practice. So that was the original idea. And if you think about the time was also sort of as we were starting to talk about patients' medical home, and the Deputy Minister of Health was coming out with the seniors initiative, and then, you know, all of the other primary care work. So we shifted with that business plan into how could this be more of a multi-physician office team-based care type project business model. And that's what it became. And so we had our business plan out of the division, and a piece of the governance model, you know, who would run this clinic was a society. That was one of the options that was explored. And I sort of looked and went, oh, this is really interesting. And Googled it and came across the Canadian Association of Community Health Centers, and then came across primarily Main Street, Morgan. As I was looking around, I went, well, this is great. People have done it before. So I started chatting in our community about, hey, we have this business plan, and it looks like people have done it. And you know, maybe this might be something that we can look at. And typical, maybe my fashion and Kamloops fashion, we had a big problem, which was people not, you know, without primary care. We knew team-based care was coming, and it seemed like an excellent idea. I'd worked in an office many years ago that had 3 years of integrated health network funding. So I'd worked in a practice where we had a diabetic nurse educator and an RT and a dietitian already. Certainly I trained essentially in a community health center, Morgan, in Newfoundland, like in the 1990s. So this wasn't new. Anyways, in a nutshell, we saw, rather than plan, we had this business plan. There was a pharmacist who was, you know, building out a new space. we had a bunch of keen community members that formed the society, and we had a bunch of new grads that needed a place to practice. So everything came together, and we just sort of said, let's do it. And so that's how our community health center at Orchards Walk came to be. It was not sort of I don't want to say traditional, but it was there a lot of in-depth planning? No. Was there a lot of enthusiasm, keenness, a space available, people with real skill sets to do this? Yes.
Okay, thank you.
That's the background on why we came to be. And I can't speak for Sun Peaks, but they probably had a very similar, sort of more planning, and they had a municipality involved. But
I want to dive in and actually come back to something you mentioned about the space.
Yep.
And I'd kind of be interested, it's at a bit more practical level, but what have you found helps to, how do you create a clinic space that actually helps to really facilitate that kind of team-based care and multidisciplinary approach? You mentioned a bit, Morgan, when you spoke about you have a figure eight and having that, the office where you can see the counselors there. But I'd be interested to hear a bit more from all of you. If people are thinking about a community health center and looking at, redesigning space, what are some things to keep in mind in terms of designing space that helps to facilitate rather than hinder team-based approaches? And who would like to go first?
Really quick, I'm jumping in.
Yeah, go for it. Why don't you go ahead?
So in a nutshell, what we did, the pharmacist that was building this space, when we found out he was building it, everything was all plumbed and everything, right? But we said, we want to facilitate team-based care. Instead of having these 2 exam rooms, we want to knock out a wall and have a bigger space where we could see, say, nurses doing assessments or sort of, because we were space constrained. We knocked out some walls is what we did so that we could facilitate sort of that ability for us to have space to communicate as a team. That was part of our plan. I'll be frank, 2 things. I'll be frank with that. We actually, in one of those spaces, had to put an exam room wall back up in order to create more exam room spaces, simply because we needed more examination rooms. That has, in my view, in our tiny space, hindered the team-based communication. There is less space where you can actually have conversations in a bigger setting, both probably with extended team members, but more importantly with the team. We just don't have that space. And then the third thing is, this is part of the, I wish we had more time and money to plan. I was really interested in what, Morgan, you may know. Sorry about this. Can I answer that? It might be the hospital. I'll put you on.
I'll jump in, Kate. I was there at Selena's space when they were just putting the walls up the first time around. So it's good to hear what she was doing. At Kool-Aid, there's a couple things that we've done. We don't have a very large space. It's larger than our last. We were in the basement of a shelter for many years, and about 10 years ago got a new space. So it was glorious by comparison, but it's not massive. A couple things that we've done. We do have shared rooms for us to do our sort of paperwork and stuff in the back. So there's lots of discussion that can happen there. And there's a couple of spots around the clinic where we can just hover and connect. Not really formally, but then the one formal place we have is we do have a group room right in the center of the figure eight. And that we use for a couple of things. And I think it's space is important, but also how you do things. So it's one thing to have a group room, but it's another thing to use it. And I think that's really important. I've been to clinics where the big room in the basement's never been used to have a team meeting before. But we have team meetings regularly and at different sizes. So there'll be different groups of clinicians might meet up. Then there's the whole team that'll meet up. And then we also use the group room for for shared care. So it might be psychiatrist working with nurse and primary care physician, seeing a bunch of patients together. Or it might be the reverse. It might be our Beyond Pain group, where it's a group of patients, or our Hep C group, again, a group of patients and one or two providers working together. So we make sure that we work together, as well as use the space to talk about how to work together. The last one is our nursing rooms tend to be a little bit bigger. We're jealous of them as physicians. But it also tends to be the place where then we get consulted into and talk with a patient. So then there's a little, 3 people, 4 people conversation. So there's that part of it as well. And then the pharmacy being right on site, we embedded that into our waiting room actually. So it's very easy for patients to connect there. And also then back to us, very easy to talk to us about, oh, is that the medication you meant? Or there's one you missed. Was that intentional? That stuff can happen really, really fast. So I think our structure of our clinic isn't that different, but there are a couple of spaces where we can connect. And then we really try to make, not highly bureaucratic, but enough touch points. During COVID, we did sort of daily check-ins, and we talked about that for, we talked about it for years and never done that. There was some resistance in our clinic to doing that. And then suddenly it was incredibly valuable for us, given all the change that was happening in March and April. And that's gone down to sort of 3 times a week, then 2 times a week now. But again, having enough space there to do that was really important.
So I would say that this is really where, we really learned the stark difference between co-location and integration. When we had our very first psychiatrist here, the psychiatrist was located in an office on our lower level, where our primary care is on our main level. And frankly, staff forgot about him. They forgot he was here. And so when we kind of restructured our program late in the 90s, we put our behavioral health staff as part of our team. And so they were embedded with our primary care team. And then as we added more and more disciplines, as Dr. Pedrosa had shown in her part of the presentation, one of the things that we have been trying to do as we've expanded our facility is typically we have had 3 exam rooms for every primary care team. And now we've gone to 4, or our goal is to have 4 exam rooms, so that rather than taking the patient down the hall to the dietitian or the psychologist or the behavioral health specialist, that the professional goes to the patient. So if the patient's in the exam room and Dr. Pedrosa needs to have behavioral health see them, the patient doesn't move. The behavioral health specialist comes in the room, or the dietitian comes in the room, or the social worker or the care coordinator, but the patient stays still and the different disciplines come to the patient. And so, if I had a magic wand for all of our clinics, rather that what we would do is to be able to expand enough so that we could have 4 exam rooms for the team, because our teams have gotten so much larger. It's no longer just a medical provider and their medical assistants. And typically there's a care coordinator and a nurse and a medical assistant, and there's a clinical pharmacist that's typically roaming the floors. But there's many more people involved. And so space is definitely an issue, but it's really around having the team go to the patient rather than moving the patient around the facility.
That's really,
sorry.
Go ahead. No, go ahead, Dr. Pedrosa.
So just to piggyback on that, it's really, a lot of it is about proximity, but a lot of it is also about privacy, so that you can have the team interactions, and there's a way to be on stage and a way to be off stage, so that certain things aren't in view of the patient, and vice versa. And so where I sit next to my team nurse. My medical assistant is right in front of me on a higher chair on a counter. Across the hall is the care coordinator. And in my previous slide, you saw me holding a tracker. I don't carry a tracker in my pocket anymore, but we've used that to get team members who are located a little farther away into the exam room without causing a lot of noise pollution by paging overhead. So, you know.
Those are some great practical, very practical examples of how to make things work. I really appreciate that from all of you. We have a little bit over half an hour left. I really want to open it up and address some of the questions that have been coming in from our audience, from our participants. So we have in the Q&A box, we have, I think 4 questions are open. I think Dr. Price has been answering some of them. So participants, please take a look at the open questions, but also click on answered so you can see both the questions and the answers to them. I would invite participants to please do feel free to type your questions, and we'll take a couple of those questions now. I'd like to start with a question, about the concerns about bureaucracy. So if, and I would direct this one a little bit more to the BC context. Dr. Price and Dr. Lawrie, if you could maybe address this one in terms of that, that balance between having a community health center, which is a different way of working than private practice, but how to do that in a way that doesn't get bogged down in bureaucracy. So how to develop those protocols and a way of working as a team, but in a way that it doesn't feel too bureaucratic. If you have any comments or thoughts on that based on your experience.
I'll jump in. So with the 2 community health centers I've worked in, one was owned and operated by a health authority, and the second is owned and operated by a not-for-profit. The health authority one, I think the secret to success there was a very strong medical director who essentially acted as an umbrella or shield from unnecessary bureaucracy, because I don't like it either. In our not-for-profit, we are the only community health center. There's only the one clinic, and then we do outreach, but it's all the same, essentially all the same team. And so internally, we define a lot of our own protocols because we want to change things internally, so we're not hitting up a lot of bureaucracy. We have a very great manager who manages the relationship with the health authority, but we are at a little bit arm's length, so there's not a lot of bureaucracy. There's a different issue for us, and I don't know if I highlighted that before. We're a sessional, so unlike fee-for-service, where you can just see more patients, and if there's more patients to be seen, a new physician can come in and see more patients, we have to negotiate a number of hours and a bank of hours per year for the clinic. And so that's a different piece of it. So that's where there's a lot of bureaucracy back and forth about what's the demand, how are we meeting the demand, et cetera. But that tends not to be at the day-to-day level.
And Dr. Lawrie, as you've been working through this, I know over the last couple of years, do you have any kind of comments or words of wisdom in terms of, facilitating and enabling team-based approaches, but within a community health center, but avoiding the bureaucracy?
I concur with Morgan. I think having strong medical leadership is really important. I think I'm probably similar to you too, Morgan, where I say I don't like it either. So I think when having a physician leader who can navigate that is really important, and not mind doing it. It's a skill set. And I think in general, I would say beyond the physician piece, ensuring you have skilled people as part of your team. If you had skilled people with the knowledge and resources in how to navigate actually setting up and running a community health center, you'll have less bureaucracy. I was also involved in setting up the Family Practice Learning Center here in Kamloops too, which is kind of like a community health center, but health authority run. And I'd say, again, managing the bureaucracy is around leadership, and luckily that had great IH management as well. A good manager will help, makes a big difference. And keeping the team small. Right. If your team's smaller, it will be easier.
sorry, I wanted to jump in also. I think we had another question from Dr. Smart, just looking at that, kind of getting that next step in terms of governance and structure. What are your thoughts in terms of governance that can help to facilitate both that kind of the connections with the community, but an appropriate team-based approach, and at the same time somehow avoiding the bureaucracy? But how does governance help that? How can governance be structured to support those broader missions? I don't know who would like to dive in on that question.
I'm going to have to go.
Okay.
So really quickly, can I answer that question?
Sure, you can answer that question and add anything else that you'd like to say before we lose you.
Okay, so I've been on a number of boards in my lifetime, actually starting with BC College of Family Physicians, super fun, by the way. And, as I reflect on what works well, it goes back to my last answer. If you have a skilled governance board, people, it will be easier. Right. It's very easy in governance, in my view, to start to meddle in operations. So how do you actually navigate and ensure that, the right people are part of the team with the right skill set? And then if you're in a community, I guess, where nobody, that skill set isn't there, being super open and lots of leadership development. That would be my suggestion. I don't know what you think, Morgan. Or I don't know the other panel members. My apologies.
As you joined late, we have Dr. Jocelyn Pedrosa and Rhonda Half, and they're working with the Yakima Neighborhood Clinic, which is a group of clinics and health centers in Yakima in Central Washington.
If you're talking simply about governance, the people who are governing have to know how to do it and not meddle in, stuff that, how do you support rather than, direct?
Well, Bob probably covered this when he did your last one, but in the States, community health centers, our boards have to be at least 51% consumers, so users of our centers. And so that's what keeps us grounded. And our governance models, our boards are policymakers. They don't get involved in the operations. They leave that to us. But they determine the needs of the organizations, where we should be located, the general service delivery. But because at least half of them, and in most community health centers, it's much more than 51%. But they are really, from the community, and they're there to identify the needs, and they kind of give us our marching orders on what services we should be offering and where we should be providing those services. Fortunately, we've had a very stable board for the last 45 years. This is our 45th anniversary this year, and it has served us well, that model.
So that gives a picture from Yakima. We're going to lose you, Dr. Lawrie. Thank you so much for joining us.
Yeah, thank you. And really quick question, that's kind of what we wanted to do here too, was where you said consumers on your board. The community, we just haven't gotten there yet. So really interesting to hear that. And thanks everybody. Sorry, I have to go.
Thank you very much, Dr. Lawrie, for joining us. And we'll try and bring you into some of the next webinars. Appreciate it. So we'll turn to you, Dr. Price. What are some of your ideas just in terms of the governance piece? I
absolutely echo. I think, I think in our Kool-Aid Society, our board is fantastic. And we're, the context of the Kool-Aid Society is we're primarily a housing organization that has a community health center, that has a dental clinic. But we have 14 or 15 different supportive housing, from emergency shelters through to assisted living, seniors housing, affordable housing. So the mandate is broader, and part of that is the clinical care. So then our clinic has direction, but not operations from a board, which allows us to be nimble and do fun things like let's set up one of the first primary care Hep C treatment programs in on the island, because we needed to, and the board was really supportive because it fit the, it supported the direction, but we actually figured out how to do that. Oh, you're muted again, Kate.
We have another question, which is kind of a technical in terms of that transition. So I might put this to you, Dr. Price. In terms of integrating traditional private practice clinics into a CHC model, like how does that work? How might that work in terms of, do those patients remain attached to that physician, or is it more the patients would shift into kind of a community, to the community health center if that were to open?
So I think that the continuity, the relationship with your primary care provider is really important. And a community health center doesn't break that, and it can enhance it. So I'll give it an example just from a couple of days ago. Even working remotely at one of the shelters, one of the team members that I work with pinged me earlier and said, I just want to talk to you about one of the patients you're going to see because I want you to be aware of. And so I was aware of some more context. The patient was really, really happy that I knew what had been going on. And that wouldn't have happened if I was just seeing the person for a visit and I didn't have the team to support the relationship. So I don't think it's an either or. I think some patients, particularly who are perhaps a bit more chaotic in our practice, are more sort of attached to the practice, attached to the community health center, but they might, we try to get them attached to one provider, but it's hard. But in general, no, I wouldn't suggest that people get sort of lost in the sea of the community health center. They're still attached to their primary care provider. The shift, though, is not just being in there as a bubble inside a building. You're not co-leasing space anymore. You're part of a team, and you want to work and change your practice to better support your patients across that team, still being their primary care provider. And I have seen where practices have been sort of parachuted into brand new community health centers, and the practice of providing care didn't change. And then there were other services in the building that effectively were referred to or not, but they weren't a team. They were just co-located. And that goes to the comments earlier, that integration versus co-location. So there's work that has to happen. And that requires time, and that requires sort of not just calendar time, but like time in the day to get people to know each other, to trust each other, and work together. And that's really, really important.
Well, we're just kind of moving into the last 10 minutes of our time together. I think most of the questions have been addressed. So I just want to open it up to the floor. If you do have a last question, please either raise your hand and we'll be able to see that and call on you, or do type it into the Q&A box. So just sort of a last call for questions here. And as we're waiting to see if any other questions come in, I would ask, Dr. Pedrosa, Rhonda, and Dr. Price, if you do have any sort of last, based on our conversation, on our discussions, any last comments you'd like to make in terms of, what really makes this work, and what's your advice to people who are thinking about making the shift over to a CHC?
We didn't talk lots about social determinants of health. Dr. Price mentioned the housing. Loved hearing that. We also have about 80 units of supportive housing throughout the valley that we provide. And Dr. Pedrosa and I were talking the other day in preparation for this, and we do social determinant screening on every patient as they come in. And obviously the people that benefit the most from that are our most vulnerable populations. But what we've learned is that even those that we consider middle class or mainstream populations, because we do these social determinant screens, we really find people who have needs that we might not have otherwise learned about, that we wouldn't have thought to ask because they look like they don't maybe have a lot of needs. And because we have the opportunity to ask them, they maybe wouldn't have revealed those to us as well. And so, I think that it's an opportunity in our kind of setting to really help people meet some of those other needs that they would not have revealed or brought out on their own. but we have certainly learned that social determinants are so important, and we have the infrastructure in the community health center model to be able to help address some of those before they turn into emergencies.
I'm so glad you raised that. We chatted about that previously, and that's such an important point. So thank you for making sure to include that. Anything else from you, Dr. Pedrosa or Dr. Price?
I'll just echo that. I think it's the early intervention or pre-emerge intervention if it's not quite early, but on a whole number of fronts, and having that flexibility within and across the team to say, we actually, so recently for us, we said we need to have more of a navigator to support the, often it's even just the physical navigation to the hospital for a test. And that becomes part of the team, and then that person becomes integral. And in fact, then that person just this week has become now part of our palliative outreach team because of how she grew across the team and where she was adding the most value. So we shifted things around. It's so neat to see how that works and how much it's supporting our patients. So I obviously I'm a fan of this model, and I just think it's a really neat way to practice, and it helps address things that I can't as a physician address, and yet I'm really pleased to see that it's being addressed, obviously, and it spills back to my relationship with my patient that we, the team, are supporting in so many different ways.
And I just wanted to kind of echo that. And, doing this work has really made it clear that regardless of which end of the vulnerability spectrum you're on, we're really more alike than we are different. And we've really benefited from having the infrastructure to support and provide care to our most vulnerable population. But it's really clear that we can apply that to the other end of the spectrum as well. When we can't find a patient, we have the means to track a patient. When they all of a sudden are in a behavioral health crisis, we can support them. And then vice versa, the ones that are, less vulnerable and maybe more economically stable have challenged us to what they expect as a consumer. Continuity of care, efficiency, timeliness of response. And so we've been able to apply that to our more vulnerable population as well, who are more focused on just surviving day to day. So I think having this, being in a CHC doesn't limit you to one end or the other, that you can really, everybody can benefit from this type of approach. It's challenging, and a lot of days it feels like a rodeo, but
Well, we're just about done with our time. I want to say a huge, huge thank you to our panelists, Selena Lawrie, Dr. Selena Lawrie, who had to leave early, Dr. Morgan Price, Dr. Jocelyn Pedrosa, and Rhonda Hauff. Really appreciate just the range of different experiences and different contexts that you're working in and being able to share that. I think I come away really, one of the points that really was important for me was really looking at the learning that can take place within those teams that actually strengthens practitioners in their ability to provide care. And all the practical aspects in terms of how you structure space and how you build a really supportive culture, as well as how you link out to external actors and then bring them in not only for co-location, but really looking at ways to facilitate actual integration. So some excellent points raised. I know I learned a lot. So huge thank you for taking time out of what I know are very, very busy schedules to come and share your wisdom and your experience and your expertise with us. It's very, very helpful. Huge thanks also to all of our participants for taking time out of your very busy schedules to come and listen to our experts, learn from them. And I hope that this will really feed our ongoing discussion about how we can structure community health centers here in the Kootenay Boundary area, how we can move towards a model that may be innovative and sort of take what we can, bits and pieces from what we learn from different actors to try and structure something that can work for us here.